So, good morning. Latvian is I guess we should. Of course, our official language is English, and we start our European course, our joint session, Russian Latvian joint session, and I guess it really will be interesting because it's dedicated to ST elevation in MI, and also which is not very clear when and why or what we should do thrombolysis, and actually we know the guidelines very well, but also the real life sometimes is completely different. And that's why I guess this session will be really interesting. I'm really happy and glad that we have our chairman is Professor Iosseliani, who is a
co-chairman.
Okay, we have two co-chairmans. My name is Andrейs, and I'm David. He's a fantastic man. He did so many things in interventional cardiology, in cardiology, of course also in our friendship, and I guess this is will be very, very interesting. What I want to say that it's always what I see and what I'm always trying to expand, that the course in Moscow, which usually take place in autumn, it's and dedicated to ST elevation, MI treatment is very, very fantastic. And this is I didn't see any other courses across the world where we can really discuss online ST elevation patients, and sometimes even the discussion is too long for patients, which is not very how to say safe for them. But it doesn't matter. That's what. And then this is the first my words are known. Please.
First, I would like to say that Andrейs is co-director of this course in Moscow at first. And now I think I would, for third cases, presenters are Days Sandor, right?
Actually, I have maybe some first slides if I can.
So,
yeah. So, and of course, you know very well, I'd like to remind and because them who's not so potential interconnection. Actually, as David says, the first case will be the delayed intervention in a patient with acute coronary syndrome and reinfarction, and we will waiting for Dr. Soldat who will present this case. And second case will be early myocardial perfusion in ST elevation MI using combined thrombolytic and endovascular therapy, what we will discuss, and I guess it's very, very and really important, and it will be done by Dr. Asada. And only one thing what I really want again to remind, if you look on the EC guidelines and the visualizations, and you see very well how it looks like and what we should do from symptom onset, then when patients are, then the first medical contact and STEMI diagnosis, and of course in the best scenario and in the what we always like very much, patients should transfer to hospital where we can perform a primary PCI in 90 minutes. Actually, we also can maybe to be a bit more liberal and to say for 120 minutes, but actually this is 90 minutes. And again, of course, it's also the question about what we always are fighting, this balloon to balloon time. But of course, the real world is sometimes completely different, and that's why we are discussing for this pathway, where you see that it's not possible to transfer patients so quick. Then we should go for fibrinolysis, immediate fibrinolysis. But then again, as you see very well, even after the successful fibrinolysis, patient should transfer to hospital and in 3 to 24 hours for coronary angiography and then to decide what to do. And this is what we will discuss today, just to understand the effectiveness and early myocardial perfusion using combined both and pharmacological and vascular techniques. Also to learn these modern trends in the treatment of ST elevations, and what I really like to say that we need to reflect the maximally early restoration of antegrade blood flow in infarct-related arteries. Okay, that's what I wanted to finish with this one. And now, as Professor Iosseliani says, Dace will present first cases, please. Really happy to see you.
Dear Chairmen, dear colleagues, today my task is to present delayed intervention in a patient with acute coronary syndrome and reinfarction. So my name is Dace Sander. I don't have any potential conflict of interest. The patient is male, 63 years old, complaining about chest pain since 9 morning. The patient called an ambulance only 5 hours later. In anamnesis, he has had previous inferior QMI 2000 and previous PCI with BMS implantation in RCA mid 2007. And now patient is taking only aspirin and Vasprolol daily. So here you can see 2 ECGs. Just I wanted to show that here you can see only some tendency of ST elevation in inferior wall. But no convincing reciprocal changes in ECG. So maybe that was the reason why the patient stayed so long time in admission department. Biomarkers showed quite large damage of myocardium. Troponin E was even 45,000 nanograms per liter. So, and on admission day, he received only aspirin. Aspirin has given an ambulance, and the department, intensive care, the department just started integralin intravenously. Actually, patient hasn't serious symptoms in our hospital. He was quite stable, so he was referred to cath lab only on the next day. Next day, he also received Brilik, ticagrelor loading dose, Clexan subcutaneously, and this infusion of integralin was continued. So before PCI, he also received additionally 10,000 of heparin intravenously. And here you can see this right coronary artery. Clearly you can see the thrombus in RCA mid. And I wanted to say that the left side is absolutely normal without any significant stenosis. Interventional cardiologists tried several times to inflate balloons, different size of balloons, but you can see that the result is not acceptable, quite large organized thrombus distally. So we can say that this STEMI flow is 0, 1. So, and my question, how would you treat the case?
Yeah. Maybe any questions?
Yeah, I guess that's a good video. There are questions, yes, please.
2 or 3 questions, no more, please.
Will you say, please, is it your routine practice to start integralin before coronary angio?
Actually, with ST elevation, yes, quite often we give integralin before PCI.
Yes. Are you satisfied?
Okay, more questions or comments? Yes, yes, please.
Yeah. Thank you. Can you say why you use balloon dilatation and don't you see a large diameter of artery, and first you don't use thromboextraction?
Maybe the reason was that this was delayed MI, and since first symptoms onset, it was more than 24 hours, and operator decided to take balloon.
But actually, I have always the same question, that you are really kind, you put my name also to this case, because you are very well treated and very well behaved, but this is and you are so experienced operator, you know, and for so many years, you've seen so many cases, you did so many cases, and it's also always a question for me, in reality, and then we have so many discussions, and why we are not using, for example, at least why we not try to use thromboextraction actually for this so big artery, and also I didn't catch what size of guiding catheter we use.
In this case, 6 branch.
Okay.
Excuse me, but for our discussion we will have the time a little late.
Right. Okay, fine. Then it's on only
now only question.
Okay.
Please, question. No more question. Okay. Next speaker is Sergei Semitko. How would I treat the case? Please.
Good morning, ladies and gentlemen, dear chairman, dear colleagues. I'm really happy to be here with you, and thank you very much for this excellent and very interesting case, because the treatment of STEMI due to huge thrombosis, one of the most interesting point in the treatment of STEMI patient, because a lot of questions are unclear absolutely. And let me say a few words about theory of this point. And first of all, you can see the risk factors are following. First of all, it's patient with moderate atherosclerotic, coronary atherosclerosis. Usually it's quite young patient, sometimes with ectatic deformation of coronary artery. We call it like positive remodeling. And of course, it's usually systemic dehydration and coagulation disorders, inflammation. For huge thrombus, it's normal when we have a patient with problem old AV grafts or stent thrombosis. But of course, it's patient with late MI, more than 6 hours from onset symptoms, when thrombus grows both direction, proximally and distally, until the ostium of some side branch, and this thrombus huge and not uniform. Usually it's multi-layers thrombus with different component with different ages. That is why it's not so simple perform completely good aspiration through the manual aspiration catheter. And so almost 1/3 of all patients with huge thrombus after PCI has some problem with tissue reperfusion due to massive microvascular embolization caused by this thrombus. And as you know, it's a very well-known point that slow no reflow phenomenon doubles of all-cause mortality. It's a crucial point in the aim of our treatment, and not even open the epicardial coronary artery and achieve some good epicardial flow, but most important, restoration of tissue reperfusion. Unfortunately, none of the existing devices provide standard and desirable effect in patient with thrombus larger than second grade. We know that manual thrombus aspiration is not so effective in STEMI patient with huge and late thrombosis, of course. And absolutely the same situation with a lot of different protective, distal protective device and rheolytic therapy and stent with covered stent, which can isolate this infarct-related lesion. And as you see, manual aspiration thrombectomy doesn't reduce the extent of microvascular obstruction in STEMI patient presenting late after symptom onset. Intuitively, we found the good decision for that patient when we firstly try to open the artery and achieve quite acceptable TIMI flow, and then leave it without any excessive mechanical forces for active anticoagulant and antiplatelet treatment for resolution, for salvation of the thrombus. And there are a lot of very, very elegant and promising study which shows the excellent angiographic and clinical result. And unfortunately, last quite big study, Dynamic 3, didn't show any benefits for this patient, but in this study, we are talking about routine deferred strategy. But on my point of view, of course, it should be selected patient with huge thrombus. If we are talking about deferred strategy, when we perform index procedure for restoration flow and then go to the medical treatment. But all of us have a lot of very exciting example with this strategy works very good. After several thrombus aspiration passage and quite acceptable TIMI flow, maybe two, we leave it into the 2, 3, sometimes 5 days. It depends on clinical situation, depend on some maybe recurrent ischemia. And then when we perform control coronary angiography, usually we see absolutely another result with another size diameter of artery and total resolution of thrombosis. We have a lot of such cases. But deferred strategy create a lot of new questions. First of all, about choice of patient for that strategy. Yes, of course, we have to assess bleeding risk, the infarct-related vessel, and of course, thrombus grade it should be higher than second grade. Another question is choice of the optimal components of the treatment. It should be maybe triple antiplatelet and anticoagulant therapy, but actually we don't know what is the best choice for this patient to be SVA or prolonged infusion of bioavailability, for example, for patient with low risk or moderate risk. And what is the best choice for him? Clopidogrel, ticagrelor, or maybe prasugrel, which it demonstrated safe and effectiveness. Maybe low-weight heparin or novel oral anticoagulant, apixaban, rivaroxaban, and unclear intracoronary infusion of some drugs. Absolutely. And the last but not least, it's duration and dosing regimen of the triple therapy and the best time for second procedure. If we are back to our case, my decision would be aspirin and clopidogrel, and we try avoid the novel. First of all, prasugrel in our country is not available. That is why we can choose between clopidogrel and ticagrelor. And if a patient older than 60 years and with unknown or moderate bleeding risk, we prefer clopidogrel, and then low-weight heparin, and of course after several thromboaspiration passages we leave it, especially if we remember that it's patient with late myocardial infarction. We can leave it without any excessive forces with low-weight heparin, and make control angio in 3-5 days, and decide maybe make a stent if needed, but sometimes we can leave it without any additional procedure. Thank you very much.
Thank you. Tell me please, you don't recommend the angioplasty in such case, concretely, in this type?
Sorry, maybe it's my fault. We recommend index procedure with minimal forces, with minimal dilatation, with 2.5 balloon, with a very gentle contrast medium injection, with very gentle aspiration, but not with a stent if we achieve quite acceptable team flow. But this case is exactly this case. It's a late in myocardial infarction without recurrent ischemia, without chest pain. We just look